Hello, everyone. This is Hassam Yunus, one of the vascular surgeons here at Cleveland Clinic, Abu Dhabi. I would like to welcome everyone for our Hassam Vascular Institute webinar. Today, our session is going to be the vascular disease, and it will be co-moderated with myself and Dr. Hassan. We will be talking about different topics, and we're very excited that we have great speakers. We'll be talking about peripheral arterial disease, carotid disease, aortic disease, as well as venous thromboembolism. And we're gonna kick our webinar with peripheral arterial disease. Our first speaker is Dr. Faisal Hassan. Dr. Hassan is the Vice Chairman of the Cardiology Department, as well as the Chairman of the Vascular Medicine Department. He's an interventional cardiologist with special interest in peripheral arterial disease and interventions. And today he will talk about intermittent claudication and tell us about how to treat, whether medically or with intervention.
Hello, everyone, and welcome to the vascular component of our webinar series. I'll be talking about intermittent claudication, medical therapy versus intervention today. I have no disclosures related to this talk. So let's start off with a clinical case. The patient that we are seeing is a 58-year-old male who presents with exertional left calf discomfort, which occurs at 300 meters. His symptoms occur reproducibly with exertion and are relieved by rest. He has a history of type 2 diabetes, hypertension, and tobacco abuse. His medications include metoprolol, aspirin, and metformin. And his examination reveals a palpable femoral pulse bilaterally without bruits. However, he has diminished popliteal and distal pulses on the left. However, he has no positional color changes or skin breakdown. So this patient presents with classic left lower extremity intermittent claudication. And when we talk about the management objectives of this patient, there's overall two goals of treating this patient. Number one is that we want to improve his mortality. And number two, we want to improve his symptoms, namely claudication. Now, why are we concerned about his mortality? So let's first start off with that. And if we look at the natural history of intermittent claudication in patients, you will see on one side is the peripheral vascular outcomes. And although these do tend to progress, it's not overly burdensome. Only 16% of patients go on to worsening claudication. 7% of patients have bypass surgery due to symptoms. And only 4% of these lead on to major amputation. What's more concerning and of a major impact to these patients is their cardiovascular morbidity and mortality. And as you can see that their event rate for a non-fatal cardiovascular event is 20%. And if you look at mortality, their 5-year mortality is 30%, out of which 3/4 of these patients die of cardiovascular and cerebrovascular causes. And if we look at the impact of peripheral artery disease on mortality, we will see that regardless of how these patients present, whether they're asymptomatic, they have symptomatic large vessel peripheral artery disease or severely symptomatic large vessel peripheral artery disease, their mortality is severely impacted. Our patient would present in the symptomatic large vessel peripheral artery disease category. And as we can see at 10 years, the survival is less than 50%. And we also know that patients with peripheral vascular disease face up to a 6-time greater risk of death from cardiovascular disease, including stroke and MI. Therefore, when we talk about treatment of this patient, the main objective or objective number one is actually improving mortality. And how do we achieve that? So the first goal is anti-platelet therapies. Either aspirin or clopidogrel can be utilized for this purpose. And secondly, risk factor modification with smoking cessation, lipid management, blood pressure control, and blood sugar control. Talking about antiplatelet therapy, there have been multiple trials, and out of these, several thousand patients included patients with peripheral artery disease. And we know that when we use aspirin, or for that matter, clopidogrel, it results in a 23% reduction in serious adverse vascular events. And the benefits are very similar, regardless of whether they are intermittent claudication, post-angioplasty, or have bypass surgery. If we compare aspirin to clopidogrel, overall the effect is fairly similar. And although clopidogrel is slightly superior with a slightly modest relative risk reduction compared to aspirin, but I would argue that they're both equally good. And if our patients are allergic to aspirin or have other contraindications, in that case, clopidogrel can be used for antiplatelet effect. What about cholesterol reduction? It has been known that not only does cholesterol reduction improve mortality, but actually also has some role to play in symptom improvement, as is seen in this study, in the Scandinavian Simvastatin Survival Study, or 4S. And as far as improvement in survival, it has been seen that in the subgroup of patients with peripheral vascular disease, statins clearly improve mortality and reduce complications and make people live longer. In regards to blood pressure control, we know that ACE inhibition results in improved mortality, and ramipril has specifically been studied for this purpose and has shown to improve mortality in patients when used in peripheral vascular disease patient subgroup. And here we can see that this effect is particularly enhanced in patients who have peripheral vascular disease. What about smoking cessation? So we have known for a very long time that when we follow patients with peripheral vascular disease, their survival is significantly improved when they stop smoking, as is seen in this study done many years ago. And so when we summarize the mortality improvement therapies in these patients, we can see that antiplatelet therapy with either aspirin or clopidogrel, antihypertensive therapy with ramipril in patients who have high blood pressure, and statin therapy in hyperlipidemic patients is the cornerstone of improving mortality in these patients. Now, our second objective in this patient is to improve symptoms. So this patient has claudication when he walks. So what do we use for that? The mainstay of therapy for improvement in symptoms is exercise therapy. And as far as medical therapy for this purpose, it's cilostazol. Revascularization for these patients, we only reserve for those who have severe disability and they fail to respond to the exercise and cilostazol therapy. Let's take a look at cilostazol. So this study here shows that cilostazol at an ideal dose of 200 milligrams a day, which is divided into twice daily dosing of 100 milligrams twice a day, works very well in improving symptoms. Pentoxifylline has been studied and showed absolutely no effect in improving walking distance. Based on the study, our ACC-AHA recommendation is to use cilostazol to improve symptoms. It is a class 1 indication, and it has been clearly shown that pentoxifylline and chelation therapy both have no benefit and therefore should not be used as medical therapy to improve claudication symptoms. What about exercise? So our patient complains of his legs hurting when he walks, and we are actually telling him to go out and walk. Absolutely, it has been shown over many studies, and this is a meta-analysis combining 21 studies that show that when people exercise, not only does the onset of claudication improve, but also their maximal claudication pain is reduced and improved. So therefore, exercise works very well in improving symptoms of claudication. How much should we tell our patients to exercise? The duration should be more than 30 minutes per session. The frequency should be at least 3 or possibly longer sessions per week. They should do it for 26 weeks or longer. They should walk to near maximal pain. And walking has been shown to be much more beneficial than combination of exercises. So what about revascularization? Where does revascularization lie in regards to treatment of this patient? Revascularization, as I mentioned earlier, is only reserved for resistant problems where they don't respond to medical therapy. And the comparison of exercise versus stenting for claudication was looked very nicely in this trial called the Clever trial, published in 2012, which showed that when we compare optimal medical therapy, exercise or stenting, actually exercise improves the walking time much more than stenting does. When we compare change in claudication onset time, both exercise and stenting are actually equivalent. And also the number of steps, if we look at them, there was no significant difference between exercise and stenting. And therefore, revascularization is a reasonable treatment option, but only reserved for those with lifestyle limitation claudication, which does not respond to adequate medical therapy. And so here's a summary slide of how to treat patients with intermittent claudication. First of all, you assess their severity for mild to moderate claudication, exercise, and drug therapy. And if the symptoms improve, then they continue with that therapy. If they move on to debilitating symptoms only, then you localize the lesion and consider revascularization only if medical therapy fails and they do not respond to exercise or cilostazol therapy. So coming back to our patient, he had resolution of his leg claudication with exercise medical therapy. He quit smoking. His ankle brachial index actually improved. His hemoglobin A1C with therapy improved. He has now been followed up for 2 years without claudication or any kind of cardiac events. And that tells us that this works very well for our patients. With that, I'd like to thank you for your attention, and we'll move on to the next slides. And with that, I'd like to introduce our second speaker for the evening, which is my wonderful colleague and a vascular surgeon at Cleveland Clinic Abu Dhabi, Dr. Hassam Yunus, who started off this session. Dr. Yunus comes to us from Baylor College of Medicine, where he was an assistant professor of medicine practicing for several years prior to joining us. Since joining us, he has revitalized our program. His main clinical interest is limb salvage, as well as the entire breadth and entire spectrum of all sorts of vascular issues. He also has a huge research interest in limb salvage, in endovascular therapies, as well as hybrid interventions. It is a pleasure working with him, and he will be talking about critical limb-threatening ischemia, the approach for such patients.
Hi, my name is Hassam Yunus, and today I'll be talking about critical limb-threatening ischemia, focusing on the treatment approach. I have no disclosures. So the critical limb-threatening ischemia represents the patients with rest pain, non-healing ulcers, or tissue loss presenting as necrosis or gangrene. And they're best classified using the Wi-Fi classification, where it assesses all components, including wound, ischemia, and foot infection. And the way to approach that is to look if the wound is ischemic or due to venous stasis, or is it a mixed ulcer. Then to assess the degree of ischemia by obtaining non-invasive vascular flow study, mainly arterial, and if needed, venous. Then to look at the foot infection, whether localized or systemic, obtain wound and blood cultures and surge markers. And if osteomyelitis is suspected, obtain bilateral foot x-rays. And if it's inconclusive, we obtain MRI or bone scan. And according to that, we can stage the disease, and which will give us an estimate of risk of amputation at 1 year, as well as the likelihood of benefit from revascularization. And the treatment goals is to relieve pain, heal the wounds, while preserving a functional limb. And while doing all that, we have to minimize the risk of other major cardiovascular events. And the key clinical points to keep in mind that the cardiovascular risk in CLTI exceeds that of coronary artery disease. Also, chronic peripheral arterial disease often requires multiple treatments, surveillance, and longitudinal care. Advanced tissue loss is very demanding. It can come with concomitant infection, and comorbid conditions often slow wound healing. Weight bearing also stresses wounds, and it can take a long time to heal these wounds. I would like to illustrate that with a few CLTI cases. The first case is a 64-year-old female that was admitted with acute and chronic congestive heart failure. She has multiple comorbidities, including coronary artery disease, CKD, type 2 diabetes, hyperlipidemia, and hypertension. Also, she has right fourth toe gangrene with elevated inflammatory markers. We obtained non-invasive vascular studies and showed severe tibial disease on the right with ABIs of 0.64. Therefore, the decision was made to perform angiogram to revascularize. This is her Wi-Fi score that we obtained by using the SVS calculator that staged this patient as stage 4 with highly benefit from revascularization, and she's high risk of amputation. This is the patient's angiogram, where it shows occlusion of the origin of all tibial vessels below the right knee, with reconstitution of the anterior tibial artery. And in the foot, the dorsalis pedis is patent and is the only feeding vessel of the foot. Dr. Faisal and I, we took the patient to the hybrid room, and we decided to perform Enterograde and Retrograde approach revascularization. Here we're obtaining Enterograde right common femoral artery access, and 6 French was inserted. That was followed by 4 French access of the right dorsalis pedis artery. We recanalized the anterior tibial artery in a retrograde fashion, externalizing the wire through the right common femoral artery sheath. Now we had through and through wire access. Then we chose to perform orbital atherectomy in this case due to the high calcification of the anterior tibial artery, followed by angioplasty of the anterior tibial artery. And this is the completion runoff, where it shows successful recanalization of the anterior tibial artery, restoring blood flow to the foot. With the benefit of the hybrid room, here our podiatrist, Dr. Prodam, performed right fourth toe amputation to control the infection. And at the end of the case, the patient had excellent blood flow to the foot. On follow-up, the patient's pain resolved. She achieved complete healing of wounds and was ambulating without difficulties. And this is our team that approached this in a multidisciplinary fashion in one setting. Another case I would like to present is a 63-year-old male patient with 2 years history of claudication. Because his comorbidities, including hypertension, hyperlipidemia, and diabetes, were not controlled, it looks like his disease progressed to rest pain 3 months prior to presentation to our hospital. And 2 months prior to presentation, he developed tissue loss, including dry gangrene of the hallux and discoloration and painful ulcers of the second and third toes. His vascular studies showed multi-level vascular disease, which was severe, with ABIs of 0.27 and toe pressure of 0. CT angiogram was obtained that showed occlusion of the right common iliac, external iliac, and superficial femoral artery. So in this case, we decided to do open revascularization. We did left to right femoral to femoral bypass and concurrent femoral to popliteal bypass to restore inline flow to the right foot. Then the wound was debrided, the patient's pain resolved, wounds healed, and he was ambulating long distance without issues. These cases highlights the need for dedicated multidisciplinary care team to approach limb salvage. And the team should have skilled individuals that skilled in medical evaluation and optimization, able to perform endovascular and surgical revascularization, as well as foot surgery, dedicated wound care team, and adjunct therapy as needed. This table summarizes our approach at CCAD in a multidisciplinary fashion, where the goals and interventions of each dedicated team is mentioned. So our goal is to control infection, revascularize the extremity, perform the wound care, offload the extremity, and medically optimize the patients. And very important component is the disposition, whether the patient needs rehab or home support, and most importantly, long-term follow-up. We were able to use all these resources efficiently and effectively that we increased the number of limb salvage cases treated at CCAD by 300% while maintaining very low amputation rate. And sometimes cases may present late and the foot can't be saved. In this case, we try our best to perform the lowest amputation level possible. For example, this is another mismanaged case where a 7-year-old male patient who had 1 year history of wrist pain that progressed to right foot toes gangrene, followed by pathological fracture of the tibia. He was treated at an outside hospital with intramedullary nail and screws, and then was transferred to our hospital due to prosthetic infection. He has multiple comorbidities. We performed right lower extremity angiogram, and it showed severe tibial disease. However, he had enough collateralization to heal a below the knee amputation. However, due to his severe coronary artery disease, he was evaluated by our cardiology team and cardiac catheterization was performed. It was deemed that he needs coronary artery bypass. Therefore, we did a concurrent off-pump cabbage and right below the knee amputation. The patient was optimized, then was sent to our sister hospital for rehab. At Amana Hospital, he underwent rehabilitation and was fitted for prosthetic, after which the patient ambulated and improved his lifestyle significantly. I'll leave you with this video. This is the front line of our limb salvage program, but as you can see from the presentation, the entire hospital contributes to this program. Thank you for your attention, and I'm looking forward for your questions at the discussion session. All right, guys. We'll open the floor for questions. I see already a question in the inbox. So the question says, why didn't we do ABG, I think aortic bifemoral bypass, in the second patient, especially seeing that there was tibial disease? Hopefully I understand the question well, versus endovascular treatment. Absolutely, these are very good points and valid options. Always we can, for flush occlusion of the iliac and the external iliac, we can always perform aortofemoral bypass. But the left side was asymptomatic. That's one option that we can leave for later, and we still can perform it. As for endovascular, absolutely. Hybrid option was a case in this, but with the patency and the severity of the patient's symptoms, we elected to do just with the go ahead and do the open surgery. However, yes, it's a valid option. Instead of up and over, I think in this approach, I usually prefer to cut down on the right common femoral artery, endarterectomize it because this one was diseased, and then do retrograde, common iliac and external iliac recanalization and stenting, and then go Enterograde and do the SFA angioplasty. But as you see, the area, the length of the area covered will be very long area. But absolutely, it's a valid option. Any other questions?
So Hassam, maybe I'll put a question in, and maybe our co-moderators and other speakers who are on the session can also chime in. So this is, I did not mention anything about dual pathway inhibition in my talk. This is the newer medical therapy option that we now have of using a combination of rivaroxaban and aspirin, as has been shown in the COMPASS trial. So I wanted to see what your thoughts are, and then maybe our other colleagues can also give us their opinion as to what kind of patients do they see should be treated, where does this lie in the current milieu of medical therapy for our vascular patients coming into our practice now.
Yes, absolutely. Very good question. The dual pathway is a new approach for these patients with a chronic PAD. So the answer, it showed the benefits in the COMPASS trial. And I think the sub-analysis was a key for me, where it showed the most patient that will benefit from this dual anti-therapy, which included the CHF and diabetes, which most of our patients are. Also, it shows benefits in patients with high-risk interventions. So before, we always did the anticoagulation for high-risk bypasses. However, like, this is now a new option that we can consider as well for that patient. Those for symptomatic ones. As for asymptomatic, what do you think, Faisal, and who do you put on that dual pathway?
Right. So I think that there's a couple of considerations that we should keep in mind. The first one being that there is an increased risk of bleeding. As we know, our advanced vascular patients, particularly those with chronic kidney disease or end-stage renal disease, are particularly prone to bleeding. And whenever we get more aggressive with antiplatelet or anticoagulation therapy, there's obviously a price for it. So I think that is something to obviously always keep in mind, that there is a slight cost to a more robust strategy. I think we see a lot of polyvascular disease in this region, where patients coming in with coronary artery disease have coexisting cerebrovascular, carotid disease, as well as lower extremity peripheral artery disease. And I think these are patients that are very difficult to treat, have extremely high morbidity and mortality, and probably stand to benefit the most from these types of aggressive medical therapies. So I think in my practice, I've started to incorporate this strategy more and more in patients who come in with multiple territories of vascular pathology.
Thank you, Faisal. There's another question in the inbox. It says, what could have been done to prevent the infection in the last case before coming with the gangrene? The doctor said malpractice. Actually, I said mismanaged. I can't say it's malpractice in this case, but what my point was, not to criticize any other physician, like we should never do. It's more about, I just wanted to point out that peripheral arterial disease can advance, and when it's critical, it can lead to limb loss. Like this patient with 1 year of rest pain, he progressed to tissue loss of the toes, and the tibial fracture was most probably, was what we found when he came here. It was due to osteomyelitis because of the progression of the disease for such a long time. As you know, with infected toes and osteomyelitis, putting a prosthetic is not the best option, because definitely it will get infected. So my point was, if I would have managed this patient a little bit early on with rest pain, most probably revascularize him at least one level. We didn't have to even have inline flow like we do with tissue loss. And when you had tissue loss, definitely should that been treated. As for the fracture, I'm not an orthopedics doctor, but definitely our podiatrist and foot and ankle surgeons here at CCE, when they saw the case, given the infection, they thought immobilization like cast or something and treat the infection would have been sufficient. There's another question here. Did you use DCP for the AT? No, we didn't actually. For this case, we didn't use DCP, but we used selectively in the patients with high risk of re-intervention, or the patient who are already undergoing interventions. But yeah, given the mixed data about the paclitaxel coated devices, we selectively use DCP, but still has its own uses as well. The other question, how successful is rehab for patient? Actually, it's been very successful because we approach it in team fashion. We start physical therapy day one after surgery, whether revascularization or foot reconstruction. And then we, as we mentioned, we partner with our sister hospital, Amana, where we send them for long-term rehab. They undergo 3 sessions of physical therapy a day, and they can be fitted for prosthetics the one they need prosthetics. Otherwise, they can be fitted for orthotists to be fitted for special shoes to prevent recurrence of these ulcers. What is your practice in checking ABI in clinics? The ABI is checked on patients who come with symptoms, or if you have suspicion and want to get baseline. We have our vascular lab, so we do check it in clinic, but it's part of, we usually get thorough examination on those patients, including PVRs and ABIs and toe pressure. Those with non-healing ulcers or who need amputations or foot surgery, then we also perform transcutaneous oxygen level. With tibial osteomyelitis, would you consider? Absolutely, you're absolutely right. So that's why we got the MRI of the leg, which I mentioned, which I forgot to mention. And we checked where the prosthetic ends as well. And then when we found that the osteomyelitis doesn't extend there, we thought that BKA would be a much better surgery than AKA because the patient would be much easier to be fitted for prosthetics, especially given his age in the 70s. But if osteomyelitis was found in the tibia, definitely the patient will have either treated with antibiotics after BKA and rechecked, or we would have got AKA. From this case and all the cases we do amputations, whether foot minor amputation or major amputations, we get proximal margin and send it to pathology. And if there is osteomyelitis, we treat it for 6 weeks of antibiotics with the help of our infectious disease doctors. And absolutely, we keep a close eye on that. Faisal, do you want to take the next one? Any role
Sure.
of lithotripsy device in calcified lesions?
Yes, I think we've got a couple of, so very briefly, absolutely, we have started using lithotripsy. I think it's a wonderful new technology. We actually have used this in treating iliac arteries prior to patients undergoing TAVR. And in this specific role, we found this device to be absolutely phenomenal. I've been very impressed with its functionality. How well it works. The couple of times that we've used it so far, we did not have to stent the vessel. We used it in the common iliac arteries to improve the deliverability of the TAVR sheath. But I think that I see a lot of major role for this particular device in the future. I think not only in the femoral arteries, but also in the tibial arteries. We should be very much be able to use it. I think this is truly a disruptive new technology that has come our way after a very long time. And I think that it is a very interesting device that we see. I foresee a lot of use not only in peripheral, but also in coronary artery disease. I think, Hassam, it's time to introduce our next speaker, potentially.
I think we answered this question as well. So we'll move on to the next section. So our next speaker is Dr. Khubaib Mopara. He's one of the vascular surgeon at Cleveland Clinic, Abu Dhabi. He recently joined us from the United States. Dr. Mopara has interest in carotid artery disease, and he was one of the first physicians that performed transcarotid artery revascularization in the state of Connecticut. Dr. Khubaib will be telling us about asymptomatic carotid artery stenosis and when we should we intervene. Can you please stop the time?
Thank you very much for giving me the opportunity to be a part of this webinar series. I'm Khubaib Mopara. I recently joined Cleveland Clinic Abu Dhabi after moving from Connecticut, US. I've been asked to talk about asymptomatic carotid artery stenosis and what are the indications for revascularization. These are the learning objectives. Before we start, I'm going to talk about a couple of cases. These are real life cases, patients I have taken care of. 82-year-old gentleman, completely functional, goes to the gym every day, typical history, previously had a right carotid atherectomy several years ago. I had been following him for his left internal carotid artery stenosis, which had progressively worsened. These are his velocities, suggestive of severe high-grade stenosis. Case number 2 is that of a younger gentleman, but sicker, previously had a cabbage, now with recurrent stable angina, has non-reconstructible coronary artery disease, also has severe right ICS stenosis. So should we offer revascularization to these patients? Are they going to benefit as far as stroke risk reduction is concerned? We know stroke causes significant morbidity and mortality worldwide. Majority of the strokes are ischemic, and a significant portion of them are related to atherombolism from carotid artery disease. Level 1 data exists regarding both symptomatic and asymptomatic carotid artery stenosis. That treatment of these with revascularization is significantly associated with the decreased risk of stroke in future. While this benefit is more dramatic in symptomatic patients, asymptomatic patients also benefit. However, more recently, several publications, mainly from neurology side, has raised some concerns that asymptomatic carotid artery stenosis may or could just be managed with best medical therapy. We will look at that data shortly. Just to put things into perspective, the percentage of all carotid interventions done for asymptomatic lesions vary widely, depending on where in the world you live, with 90% of all interventions and surgeries in US done for asymptomatic lesions versus 0% in Denmark. That's quite a contrast. So let us look at the data. What does the data say? There have been 2 landmark trials looking at asymptomatic carotid stenosis, the ACAS and ACST trials. Both of these were done in 1990s, 2000s, well-conducted randomized controlled trials, which randomized the patients to either best medical therapy, comprising mainly of anti-platelet therapy and some statins, and carotid revascularization with mainly carotid atherectomy plus best medical therapy. And both of these trials showed a statistically significant reduction in the risk of stroke in these patients compared to patients who were treated only with best medical therapy. And the perioperative risk of stroke in patients undergoing CEA was about 3.1%. Now, I emphasize this because these were all obviously included in the overall risk of stroke in patients who underwent carotid atherectomy and best medical therapy. I believe that these numbers are lower today compared to the past, and we will look at the significance of this in a while. Meta-analysis of these trials also clearly show a small but clear risk reduction, an absolute risk reduction of 3% over 3 years. The therapeutic margin is quite narrow, meaning the number of patients needed to treat, number of patients needed to prevent 1 stroke is about 33 patients at 3 years. So this raises an important issue that for us to get any benefit of revascularization in asymptomatic patients, patients have to have a good at least 5-year longevity or life expectancy, and the perioperative morbidity and mortality have to be kept low. Based on these trials, major vascular societies have always recommended carotid revascularization for severe asymptomatic carotid stenosis, as long as patient has a good cardiac risk and good anesthetic risk. So this brings us to the point, why are we even talking about it? As I mentioned earlier, recent publications have raised some concerns that modern medical therapy is so much better, especially with the lipid-lowering statins and aggressive control of blood pressure and smoking cessation techniques, that medical therapy provides the same risk reduction as carotid revascularization, and some reports suggesting maybe better. So is this really true? And to answer that question, we have to look at the natural history of asymptomatic carotid lesions, or patients who had asymptomatic carotid stenosis who were maintained on best medical therapy. There are several retrospective series and studies available. This is the one from Cambria's group. This is a retrospective study of close to 800 patients with asymptomatic carotid stenosis, and all of these patients were managed with best medical therapy, aspirin, statin, with the lipid LDL of less than 100 in all of these patients. And the thing to note here is that at 5 years of follow-up, about 45% of these patients had progression of stenosis or development of ipsilateral symptoms. This is a significant number. This is a large natural history study, the ACRS study, which looked at over 1,100 people who were followed with 6-monthly duplex with asymptomatic carotid stenosis. They were all maintained on best medical therapy, and progression of stenosis was seen in about 20%, regression in 4%, and the rest remained stable. The risk of ipsilateral stroke was directly associated with whether they progress or not, with 16% risk of stroke at 8 years in patients who progress versus 9% in patients who remain stable versus 0%. The overall risk of developing ipsilateral cerebrovascular events or having retinal ischemia or amaurosis was 12% while on best medical therapy. This means that medical therapy failed to provide stroke in 1 out of 10 patients, and this is the best medical therapy that we are talking about. So in my opinion, the proponents of the notion that best medical therapy alone can treat all patients with asymptomatic carotid patients fail to recognize 2 important points. One, which I believe is not talked about much, is the improvement in carotid endarterectomy outcomes. With the improvement in perioperative anesthetic techniques and surgical techniques in general, the risk of stroke or having an MI after CEA is lower today than what it was in 1990s. And several studies from US and Australia have recently shown the perioperative stroke rates to be about 0.5 to 1.2%. When this is added to the picture, the actual overall stroke rate in patients undergoing CEA plus best medical therapy may actually be lower. In addition, I don't think it is, I think it's false to assume that all asymptomatic carotid lesions are the same and that one size does not fit all. We know that there are asymptomatic patients who have calcified fibrotic plaque, and when we do carotid endarterectomies, we open them. There is no plaque features or softness in the plaque, and it looks very fibrotic, smooth plaque. Those plaques are inherently different than people who have ulcerated plaque or people who have lipid-rich hypoechoic plaques. And clearly, there are lesions that progress while on best medical therapy, and these features suggest that these plaques may be at higher risk of embolization. Several studies suggest that. These are just some of the examples that show that plaques that progress or plaques that have high-risk features are clearly at higher risk of atherombolization, causing symptoms and stroke. So this raises an important point that there is no such thing as symptomatic or asymptomatic patients. There are asymptomatic patients who may have stable plaque or may have unstable plaque. And plaque features like the ones listed below or plaques that progress may suggest that these are unstable situations. And these patients, even if managed with best medical therapy, have a higher risk of progressing and we may become symptomatic in future. And their risk of stroke may be higher. So one size doesn't fit all, as I said earlier. Not all asymptomatic carotid lesions are the same. And while it is true that 80 to 90% can be managed with best medical therapy, we have to use our clinical judgment. And in my opinion, it's an individualized decision depending on the plaque features, the patient features, whether they should be offered carotid revascularization or not. Till we have more data from CREST-2, my approach to management of patients with asymptomatic carotid lesions is as below, that patients with mild to moderate stenosis, they can be safely managed with best medical therapy plus annual surveillance with carotid duplex. Whereas patients who have severe stenosis with end-diastolic velocities of over 120, suggesting critical stenosis, or patients who clearly progress while on best medical therapy are at higher risk of becoming symptomatic, or worse, have a higher risk of severe stroke. And if these people have good 5-year life expectancy, I offer them carotid revascularization. So going back to our cases, case number 1, as I said, fully functional guy, independent, had progressively worsening carotid stenosis. I offered him carotid atherectomy. He did very well, was discharged on day 1, and was doing well at his for a 1-year follow-up. And this is a sicker patient with non-reconstructible coronary artery disease. After discussion with his cardiologist, we decided to just treat him with best medical therapy, and we did not offer him any carotid revascularization. Thank you very much.
Thank you, Khubaib. That's a great talk. I think we'll move on with our next talk, and then we'll have Q&A session. So our next speaker is Dr. Michael Park. He is the Chief of Vascular Surgery at Cleveland Clinic, Abu Dhabi. He joined Cleveland Clinic, Abu Dhabi about 4 years ago, coming from Cleveland Clinic, Ohio. Dr. Park has special interest in abdominal and in aortic aneurysms and imaging. And today he will be talking about abdominal aortic aneurysm, endovascular versus open repair.
Hello, I'm Michael Park. I'm the Chief of Vascular Surgery at the Cleveland Clinic in Abu Dhabi. I'm going to talk today about the decisions involved in choosing between endovascular repair and open surgical repair of abdominal aortic aneurysms. EVAR, or endovascular AAA repair, is the most common way aneurysms are fixed nowadays. It's done with stents, wires and catheters, and typically done percutaneously with very short procedural times and short length of stays. It can even be done under local anesthesia. The results are very good in the short term. You can see here a patient before and after stent graft repair of their abdominal aortic aneurysm. Open surgical repair is the traditional way of fixing these aneurysms, and it's becoming quite a bit of a lost art. Many centers have abandoned open surgical repair for endovascular repair, and the trainees have suffered from this in that they are often exposed to very few open surgical repairs. This is not the case at the Cleveland Clinic in main campus. When I was there up until 2017, the most common open surgical repair of the abdominal aorta was, in fact, explantation of failed endovascular stent grafts. These choices that we make, the patients and the surgeons' choices, have consequences, and I'm going to discuss these in the talk. It has consequences for surgical training, and has short-term and long-term consequences that may, in fact, change your mind about which one you would want if you were to get an aneurysm. Let's start with this patient who came to us about 2 years ago. 63-year-old man, COPD, former smoker, with a 7.5 centimeter AAA, with a short 10 millimeter neck that's angulated, large AAA sac, and iliac aneurysms. Now, I go through the indications and risks in detail with the patient, and also the treatment options, including open surgical repair endovascular repair and the consequences of doing nothing, the natural history of this disease process under best medical therapy. A patient with 7.5 centimeter AAA faces, in fact, a fairly high risk of rupture spontaneously over the next year and over the next 5 years. And so repair is recommended. If the patient chooses Evar, we must stick to the instruction for use for these devices as a rule, and the patient must be informed that they need to follow up for life. You can see here the short-term results of endovascular repair are quite good. Within the day of surgery and within the first 30 days, mortality and device failure rates are close to zero. These are from the device's FDA approval trials. And in fact, during the early part of the 2000s, when the endovascular stent graft repair was adopted, you can see that in fact there was a learning curve. Evar initially had similar mortality to open repair, but soon it dropped to less than 1%. And open repair had the 4% that's commonly quoted in the Medicare database. Centers of excellence will often have 1 to 2% risk of death with open surgical repair, but in fact, it will usually get beat by Evar. What was less known is that, in fact, every comparative study done between Evar and open surgical repair has this crossover effect. You can see on the top graph here in green and purple. The open surgical repair has that initial dip in surgical mortality, but then the aneurysm-related mortality stays quite stable, whereas there is a constant rate of aneurysm-related mortality related to Evar. So there's a crossover in survival related to aneurysm-related death when you compare Evar versus open surgical repair. And so at the 5 to 8 year mark, depending on which study you see, there is randomized control data showing that long-term these are no longer equivalent, but in fact the Evar is inferior in terms of aneurysm-related death. This patient chose Evar, so that graph, that picture I showed you earlier was that patient with a short angulated neck. We were able to get a good seal and see that the results were quite good. And we followed up with CT scan at 1 month after procedure and at 1 year. There was a few millimeters of shrinkage of the sac. And the patient then asked me, hey doc, why do I need to follow up every year for the rest of my life? And I've been asked every one of these questions on this slide. In fact, one of the patients poignantly asked me, like, my brother has metastatic colon cancer in remission. He needs a CT scan every year. Why do I need a CT scan every year if I've been successfully treated with stent grafts? And in fact, that's because the trial data shows that a certain number of these patients fail and rupture their aneurysms. The worst situation is when the patients stop showing up for their follow-up. And that is a bit of a disaster, in my opinion, and we track these patients down. These patients, long-term after Evar, have a higher rate of CKD, possibly related to the contrast given in CT scan. And in fact, there's been a shift towards duplex follow-up in these patients, especially those that have sac shrinkage. If you look at the patients who have had stent graft repair under the instruction for use, it's quite sobering. They have sac enlargement, which portends sac rupture, even when they follow the instruction for use. Outside instruction for use, the people who place stent grafts on the cutting edge of indications, it's an independent risk factor for sac enlargement and rupture. This is new data that just came out under electronic publication. Patients with large aneurysm sacs, to begin with, have a higher rate of rupture after stent graft repair compared to those who had smaller sac. But in fact, that 6.5 millimeter boundary, you can see that people with less than 6.5 centimeters still had a 7% rate of rupture at 5 years. And this is from the large VQI database, which is a multi-center database. The reason why, the short answer to the reason why is these stent grafts aren't durable in the long term. These stent grafts are constructed from graft and sutures and metal stents, and these suture points, in fact, cause holes, and it can cause wear. Also, the dynamics of blood flow can push stent grafts apart, and the aneurysm can grow in the neck where they're sealed. So that's why these can fail. This is a short slide showing, in fact, the patients who get these can often get multiple CT scans. This patient had their repair done for 4.5 centimeter AAA, which was not indicated at the time at 4.5 centimeters. He ended up having 17 CT scans in 7 years because his sac kept enlarging. We ended up resecting his stent graft. This patient had a ruptured aneurysm, and I repaired it with a stent graft. But after he woke up, he told me, "Doc, I'm going back to my home country in a year or two, and we don't have the facilities, and I don't have the money to follow up with CT scans." That makes me quite concerned. And this patient, in fact, here in country, has been found to have endo leaks and has had multiple CT scans for abdominal pain. So again, although he survived his rupture, which has a high death rate, it makes you wonder if we did the right thing with placing a stent graft. Our CCAD experience has been quite good. We have had 29 elective aortic surgeries, both endovascular and open. The urgent surgeries have had no mortality. The emergent surgeries, those who ruptured, had 4 out of 20 patients having a 30-day mortality. Again, that shows some selection bias in that the patients who do get referred have to survive their transfer. If you look at specifically the infrarenal AAAs, open versus Evar here, we're in fact a low volume center. The population here has skews towards having high rates of diabetes, which portends having lower rates of aneurysms. But that said, we've done a fair number of open AAA repairs with good results. The guidelines here show, in fact, the SVS versus European versus the British guidelines, and they all right now opt for choice between open and endovascular repair. The European guidelines are a little bit more nuanced in offering open repair for those with better risk. What's interesting is that in the UK, the NICE UK guidelines specifically say there's no role for Evar in elective aneurysm surgery, and they recommend open surgical repair. This is quite controversial, but in fact reflects their costs. And this, in fact, this patient with iliac aneurysms had the option of open and endovascular repair, but when I told him he would need annual follow-up, he said, "I have to pay for all this out of my own pocket. I'm going to just have this fixed once and then be done with it." We did open surgery. He stayed 5 days in the hospital and went home and did quite well. So in fact, guidelines do offer some sanctuary or safety, but in fact are quite muddled in terms of recommending open versus endovascular at this time, except for the British guidelines, which are quite strict. The patients must have lifetime follow-up after Evar. Informed consent must include a credible offer of safe open surgery, and cost will determine the future decision tree. Thank you very much for the opportunity to speak.
Thank you very much. Great talks. And we have both speakers online. Let's start with the questions. Dr. Mopara, how do you discover asymptomatic patients? Is there a screening program in the US? I guess you presented that we have 90% asymptomatic carotids there. So let's see, what do we do? How do we get all these numbers? And then don't.
So in general, there is no recommended screening programs for asymptomatic carotid stenosis, mainly because the prevalence in general population is quite low. So the number of patients who would need to be screened in the general population would be extremely high to actually get any benefit or prevent a stroke. However, targeted screening is talked about and recommended by some, but is also controversial. When I say targeted screening, I mean people with atherosclerotic risk factors, vascular patients, and people who have a BRUI are commonly patients who undergo carotid duplex, which is the method of screening. When I talk about patients who already have atherosclerotic risk factors and undergo screening, most of those patients are already on best medical therapy. But if you pick it up, you can follow them, and obviously, depending on the indication, they may have some benefit out of carotid revascularization. So to answer the question, in general, there is no recommended screening guidelines in the general population. However, high-risk patients can be screened with a carotid duplex.
Thank you. So, Dr. Mabara, while we have you, so I have a question for you about the dilemma of patients who have asymptomatic carotid stenosis, critical stenosis, and present with coronary artery disease syndrome. Those patients many times require coronary artery bypass surgery. Then the question, do we treat that carotid, and in what sequence?
That's an interesting question, Hassam. So this is probably, asymptomatic carotid stenosis is probably one of the most debated topics right now amongst vascular, neurology, neurosurgery literature. And as I said, there's a lot of debate going on whether asymptomatic patients should be treated or not. Now you're adding one more picture to it, which is patients who have coronary artery disease and are picked up to have asymptomatic carotid stenosis. So people undergoing coronary revascularization via carotid, via CABG, they have many risk factors for perioperative stroke from a CABG standpoint. Mainly atheroembolization from aortic atheroma. So aortic cross-clamping, insertion and removal of cannulas, on-pump CABG. Most of the strokes that happen due to carotid lesions are atheroembolization and not hypoperfusion stroke. So in patients with unilateral carotid artery stenosis, which is asymptomatic, and who require CABG, there is no data that supports that they should undergo carotid revascularization either prior to CABG or simultaneously. However, people with severe cerebrovascular disease, like carotid occlusion on one side and severe stenosis on the other side, or in the presence of vertebral disease, hypoperfusion is potentially possible giving a stroke when they undergo on-pump CABG. And those patients can potentially be treated even in the presence of asymptomatic carotid lesions. So the data says that people who undergo, there are three options for treating asymptomatic carotid stenosis, either at the same time, like combined carotid CABG, carotid first, which should not be done because the risk of MI and stroke is higher, and CABG first and then carotid. The data supports that combined carotid CABG is safe and can be done. Whether you have the right indications to do it or not is what we need to talk about. And I think, in my opinion, people with unilateral carotid stenosis, there is no data to support it. However, you can make a case for somebody with severe bilateral carotid stenosis or four-vessel disease who require CABG. They can potentially be treated with combined carotid CABG to get any benefit.
Thank you very much. Dr. Park, we're going to switch to you. I guess I know the answer, which treatment modality you would prefer if you get an aneurysm, but you beat it too hard on the screening after EVARs that the patient requires CT scan yearly. And we have multiple questions saying, why not ultrasound?
I absolutely agree. I think that there's more data, and it was my practice early on that when patients have shrinkage of their aneurysm sac and about half the patients will show, a little bit less than half will show clear shrinkage of the sac. That after that delta, that change is demonstrated by CT. You can follow them safely with ultrasound, and ultrasound is very effective for picking up endoleaks, particularly the dangerous kinds, with a good imaging team. The real issue is follow-up. Several publications have shown that it's in the U.S., even with in the Medicare database and VQI, that follow-up compliance is shockingly low, and in fact, up to 50% of people just stop following up, and that is a formula for disaster. Usually, then they present with a rupture. Some of the endoleak is missed, and the rupture. My general rule of thumb is if they're older than 70, they should get an EVAR. If they have cardiac risk factors, and usually they do, they should get EVAR. But it has to be shown to them that they must follow up regularly with their physician. Patients who are younger than 60 should get open repair unless they have crippling cardiovascular risk factors. The people in between are the ones that need this discussion, and you have to have informed consent. You have to offer both open repair and endovascular repair to walk through the risks and reasons why one is better or less suited than the other. And people usually choose endovascular repair given the short-term benefits, but the data is very clear right now that these endografts form a sort of temporary repair that starts degrading after 5 years.
Thank you. Thank you. There's another question, which I assume that it's more for screening before intervention. It says, what's your preferable screening for aneurysms? Do you have certain size where you prefer ultrasound, then you switch to CT scan, or is it the body habitus?
No, it's so in general, I don't go screening the whole aorta. In patients who have the typical risk factors right now of age over 60, a smoking history, and they've never had screening, they should get screening based on the current guidelines. The thing that we have here in the UAE is that there's a high prevalence of diabetes, which is a protective factor against aneurysm formation, and so screening is not likely to benefit. Universal screening is not likely to benefit the population sort of in a general fashion, but focused screening on people who have risk factors, who have family history of aneurysms, should be done. It's very simple. It's an ultrasound examination of the abdominal aorta. Some general rules of thumb for me are that patients who have smoked like a chimney for decades and who have palpable DP pulses should probably get screened for aneurysms if they're over 60 years of age, because like they probably have grown aneurysms, and I have a bunch of rules of thumbs, but basically I follow the guidelines.
Excellent, thank you. The question about choice of antiplatelets or anticoagulation therapy post-Evar. Do you use any, or do you have any preference?
Yeah, so they should be on aspirin, and their cardiac risk factors should be managed for long-term survival. There's no data to support anticoagulants in these patients. But that being said, again, I've started applying anticoagulation aspirin therapy for patients who have multi-bed atherosclerosis and high atherosclerosis burden, but these do not tend to be patients who have aneurysms.
I'm going to change that question a little bit. You get many calls that the EVA, we have a patient with AAA, incidental finding of AAA, and the radiologist called with critical finding of heavy mural thrombus. Would you anticoagulate? Can you clarify that for us?
Yeah, absolutely. The mural thrombus is a reaction to the widening of the blood vessels. So when the blood vessel widens, typically there's eddy currents. So if you imagine a river and it widens, the flow slows, and at the sides, more silt deposits and builds up. And so the channel itself, the deep channel, is still the same, but on the side of the river, it's very shallow and filled with silt. That's what happens with aortic aneurysms. As it widens, thrombus forms in a concentric fashion because of lack of flow. Not everyone has that, but most people do have mural thrombus, and we don't specifically anticoagulate for that mural thrombus unless the patients have problems with atheroembolism. But again, that would be an indication for treating the aneurysm. Although in between we bridge with the therapies.
Okay. Thank you very much. We have a question. Did you do conventional EVAR on the 10 millimeter angulated neck, or should we consider FEVAR at that point?
Yeah, that's a great question. That patient fell under the IFU for the Endurant device, which lets you treat a 10 millimeter neck with some angulation. It sealed well. There's a school of thought that these patients, most patients would benefit from FEVAR at the renal level, because the natural history of the disease is that the aneurysm progresses upwards, particularly if there's an endo leak, and so that you would lose the seal proximally with these shorter necks. That being said, this patient is right on that borderline zone where I don't really push hard for open repair. And I don't think that the data supports FEVAR over EVAR in this particular situation.
Thank you. The next question for Dr. Mopara. I think the question asking carotid stenting when. I guess you focused a lot on the carotid endarterectomy. Maybe you can give us a brief indication of when do you stent and when do you use TCAR?
So I mainly talked about carotid revascularization when I presented most of the things. So you could talk about carotid stent or carotid endarterectomy. Most of the trials were done with carotid endarterectomy. However, my general approach to patients with carotid stenting is people who have anatomically or who have anatomical risk factors for carotid endarterectomy or open carotid surgery. Those patients are usually people with hostile neck, redo carotids, previous radiation, tracheostomy, things like that, or a very high lesion. Those patients certainly I would consider carotid stenting. And when I do carotid stenting, I have pretty much moved over from transfemoral to transcarotid, and mainly because of the lower risk of, significantly lower risk of stroke associated with TCAR. Asymptomatic lesions, again, I follow the same guideline when it comes to the stent versus carotid endarterectomy. There is this whole concept of physiologically high-risk patients who may not tolerate a carotid endarterectomy. I've yet to come a patient like that, unless somebody who has unstable angina and is really waiting for coronary revascularization and needs carotid surgery at the same time, which we just talked about. It's a very rare situation. Certainly in that situation, I would consider a carotid stent prior to undergoing CABG. But in general, I reserve it for anatomically high-risk patients. And as I said, I do most of them through a transcarotid approach.
Thank you very much. I think the next question has been answered. Why not ultrasound for post-Evar surveillance than CT? I think we discussed that if the ultrasound is available with comfortable techs, that it's valid option, but if it's not, then we have to go to CT. So you have to keep that in mind, that the ultrasound might not be available, but if it's available, definitely it's a great dynamic study that, especially with endoleaks, you can see the flow, the jet of the flow, and the direction of it, and so forth. The next question, is aneurysm maybe genetic?
Yeah, that's a great question. Several multiple groups have searched for an aneurysm gene. It certainly there is a familial pattern of inheritance of aneurysms, and there are several publications of family cohorts of father to parents to children, and among siblings. But specifically an aneurysm gene has not been found. But there's several candidate hypotheses. When I was a resident, I worked with Dave Tilson, and his theory was that aneurysms are a autoimmune disease. It's not an immune phenomena that occurs with degeneration of aorta. And reaction of the immune system against it. There's a body of evidence for that, but it's most likely that it's a combination of environmental effects of smoking, hypertension, as well as genetic effects that are probably multifactorial. But again, it's something that seems to have afflicted mostly European populations, although we see it in Asian populations as well, as people's diets have changed, people's body habits have changed, and smoking prevalence spiked in the Cold War and post Cold War eras. But right now there's no specific aneurysm gene that we know of, but it's probably a multifactorial process.
Thank you, Mike and Khubeb, for a wonderful session and excellent questions from the audience. I think there was a great deal of interest in this section. And we'll, with this, move on to our next speaker. It gives me a great pleasure in introducing Dr. Lebin Tefera, who's a staff physician in the section of vascular medicine at the Heart and Vascular and Thoracic Institute at Cleveland Clinic main campus. Dr. Tefera trained at Mass General Hospital and is currently staff physician in Cleveland Clinic. He will be talking to us today about pulmonary embolism management, comprehensive team management approach.
Hello, my name is Dr. Lebin Tefera, and today I will be presenting pulmonary embolism management, a comprehensive team management approach. I am a staff physician here in the section of vascular medicine at Cleveland Clinic main campus in Cleveland. I have no financial disclosures. And so for the agenda, we'll be talking acutely or preliminary about the acute pulmonary embolism, the scope of the problems. We'll be doing a description of the multidisciplinary approach to PEs and the multidisciplinary follow-up care of these patients in our clinic. But first, we'll start with a patient case. This is a 61-year-old female with a past medical history of hypertension, hyperlipidemia, type 2 diabetes, who presented with a 2-week history of cough. She'd been caring for her husband, who was COVID positive. On the morning of presentation, she experienced acute onset abdominal pain and presented to the ED. In the ED, her vitals were significant. She was hypertensive, tachycardic, respiratory rate in the 20s. She was hypoxic with correction with 2 liters. On exam, she was uncomfortable and anxious. Her labs were notable for a white count of 14, a D-dimer greater than 8,000, and a rapid COVID test returned positive. On imaging, we obtained a CTA chest, abdomen, and pelvis. At this time, her CTPE was negative for PE or any acute arterial visceral thrombosis. Here we have the chest X-ray, which is very classic of COVID with the bilateral patchy opacities. Again, same thing, classic CT finding for COVID. But incidentally, we found that she had a right ventricle filling defect concerning for venous thrombosis. She also had arterial thrombosis within her aorta in 2 different locations. So there's one, there's another. And here is a bedside echo, and you can see poor quality is bedside, but you can see that RV thrombus flailing around. And so returning back to pulmonary embolism, we'll come back to that case. Who really needs multidisciplinary care anyways with regards to PE? So one, PEs are quite common, 60 to 70 per 100,000. On autopsies, you'll find that 30 to 45% of patients have had some evidence of PE. PE is the 3rd leading cause of cardiovascular death behind stroke and MI. We hear a lot about stroke, we hear a lot about MI, but we typically don't hear about pulmonary embolism in the news. Many subspecialties are involved in the care of these PE patients, including vascular medicine, hematology, pulmonary care, and cardiology, but really no one specialty takes ownership of these patients. Whenever I was a fellow, my mentor called PE the orphan's disease. But we're seeing it more so in the news. Recently, or a couple of years back, Serena Williams was temporarily sidelined with recurrent pulmonary embolisms. Chris Bosh, who was an NBA basketball player, had to end his career early due to recurrent blood clots. And so when we talk about blood clots, what are our treatment options with respect to pulmonary embolism? And really it breaks down to 2 things, anticoagulation and more advanced therapies. Within the realm of anticoagulation, we have unfractionated heparin, Lovenox or low molecular weight heparin, DOAX, and warfarin. And when it comes to advanced therapies, we have our thrombolytics, whether that be systemic or catheter directed. We have our mechanical therapies, where we use a lot of Inari here, or thromboaspiration, and we have adjunctive therapies such as IVC filters and ECMO. But when we talk about PEs, which therapy is the best? And it really depends on a patient basis. There really is no standardized approach to coming and treating these patients, and strategies are really all over the map. You know, it depends on the medical service the patient's admitted to, the location, the size of the hospital, the resources available at the hospital. There really is no consistency in decision making, which makes it very difficult to treat these very sick patients. And there really is no accepted algorithm when we look at the data. And so in 2019, things got a little bit better when the European Society of Cardiology released their 2019 guidelines for the diagnosis and management of acute PE patients. But still, when we look at the literature with respect to massive and submassive PEs, there's very little guidance in terms of treatment. So coming back to our patient that we talked about early, she was started on a heparin drip. She was transferred to the floor. She was started on IV antibiotics and hydroxychloroquine. This was very early in the COVID pandemic. However, acutely, she had worsening hypoxia. Her oxygen need went from 2 liters to 8 liters. She was only satting 90%. She was prone. And at this time, there was concern for embolization of that previously visualized RV thrombus. She was transferred to the CICU and a PERT was activated. And so what exactly is a PERT? So PERT stands for Pulmonary Embolism Response Team. And the objective of this PERT team is to provide and coordinate care for these high-risk PE patients and advanced PE-related care within the institutions these PERT teams are housed. And if we're coming back to that 2019 European Society of Cardiology guidelines, it is a 2A level C recommendation that each institution has or sets up a pulmonary embolism response team. And why do we need these pulmonary embolism response teams which provide multidisciplinary care? And this is pretty much why right here. This is a figure from MGH, but as you can see here, we have tons of lines, and it depends on where the patient's coming from, whether it be within the hospital or from an outside hospital. Where does the patient get discharged to after therapy, whether that be anticoagulation or catheter or surgery? And the whole purpose of a PERT is to really streamline this care. So whether the patient's coming from an outside hospital or coming from within the hospital, the PE should be identified, the PERT team should be activated. After the PERT team is activated, there should be a multidisciplinary team meeting with various participants that we'll go through later, and a disposition plan and treatment plan will be identified for that patient within that meeting. And so who participates within that meeting? Several participants. You have vascular medicine, pulmonary critical care, cardiac surgery, imaging, quality, research, hematology, emergency medicine. Really depends on where the patient is coming from. But you can see here that we have several participants within these meetings. And this is just a more streamlined image showing what actually happens during these PERTs. So the patient is identified from the emergency department, the floor, or an outside hospital. A PERT fellow who is in-house 24/7 is notified and actually sees the patient and does a history, physical exam, a bedside echo, and now our fellows are doing lower extremity venous duplexes as well. The patient is risk stratified according to low risk, submassive, or massive. And for submassive or massive PEs, a multidisciplinary team meeting with the patients or with the specialties that we spoke about earlier, join an electronic meeting and a decision regarding treatment is made, whether it be anticoagulation, lytics, or catheter-directed therapy. And so logistically, what does this actually look like? We utilize a video conferencing messaging system where we have a group email distribution and group paging system, which notifies doctors that a PERT is being activated. The fellow is allowed to control the screen and actually go through the imaging with all the participants. And this case is discussed virtually quite extensively, and a decision is made usually within minutes. And so what does this look like again? Within the hospital, our goal is to provide care for these patients within 3 hours from the patient entering in the door. So once the patient is identified as having a large PE, within 3 hours, we want to provide care to that patient. 3 hours sounds like a long time, but the biggest delay typically comes from the ED or the ICU identifying the patient and actually notifying the PERT team. Once the PERT team is actually activated, usually within 20 to 30 minutes, a decision has been made regarding care for the patient and our treatment is carried out. And so in our hospital, you'll see these signs all over the hospital on walls, on screensavers, saying that if there is a severe pulmonary embolism, the 2 PERT pagers should be activated. That way our multidisciplinary team can react to these acute PEs. And so coming back to our patient, vascular medicine, pulmonary critical care, hematology, and cardiology all participated within this multidisciplinary team meeting. The case was discussed extensively. Given the fact that the patient had arterial as well as venous thrombosis, we decided to give the patient 50 milligrams of TPA. She was observed in the ICU overnight. Within 2 hours, her oxygen requirement came down from 8 liters to 3 liters. And over the ensuing day, she was actually weaned back to room air. And she was discharged home on her 40th wedding anniversary on Xarelto. And so really quick, I just want to talk about follow-up. We often discuss multidisciplinary care with regards to inpatient care, but here at Cleveland Clinic, the main campus, we've extended that to outpatient care as well, and actually have come up with a Pert Clinic. And the objective of our Pert Clinic is to develop protocols for longitudinal care of these patients using that same multidisciplinary team approach. It's really streamlined by vascular medicine at the center of all these cares, but we are able to refer patients to oncology, pulmonology if you're concerned about CTEPH, or cardiac rehab, or behavioral therapy for patients that we see that have a high incidence of anxiety and depression following a massive PE or submassive PE. And so what happens at our 1 month, 3 months, and 6 months visits are listed here in this table. This will be made available for everyone. And we keep track of all of our data from all of our visits in a REDCap database. This allows us to do great quality control and to see how our outcomes are of our multidisciplinary care, inpatient and outpatient. One thing that we do or we're working on right now is actually virtual visits for these PE patients to make sure they are not lost to follow-up. And so in terms of takeaways from PERTs, PERTs allow us to provide coordinated real-time consultation from a multidisciplinary team approach. It allows expedited response to critical events in these patients with very sick, that are sick secondary to massive or submassive PEs. It allows us the ability to coordinate these complex therapeutic decisions and really mobilize these necessary resources, which can be difficult for these patients. And so our motto here at Cleveland Clinic is every life deserves world-class care, but we're changing that to every PE deserves world-class care. My resources, thank you very much.
That was an excellent talk, and I'd encourage all participants to keep typing in the questions so that we can address them as time goes through. And next, it's my pleasure to introduce Dr. Marcelo Gomez, who is the co-associate section head of the section of vascular medicine at the Heart and Vascular Institute at Cleveland Clinic main campus. Dr. Gomez will be talking about DVT treatment approach.
Thank you. Good evening, everyone. Thanks for joining our webinar program. And my name is Marcelo Gomez. My talk to conclude this session is acute DVT treatment approach. And we'll start with a short clinical case. A 44-year-old woman presents to the emergency department with a 2-week history of right lower extremity edema and below the knee and right calf pain. Her symptoms began 2 weeks after she underwent a partial mastectomy for left breast cancer. She was hospitalized for about 4 days. She had no other symptoms on presentation. Her past medical history is significant for a left calf deep vein thrombosis. A few years ago, while she was taking an estrogen oral contraceptive for endometriosis. Just very brief information about her physical examination. Her blood pressure was normal, heart rate was 92. She was obese with a BMI of 34. Heart and lungs sounded fine. There was a 2+ pitting edema in the right lower extremity, no cyanosis, and the peripheral pulses were palpable and symmetrical. Obviously, for the case and the purposes of our presentation, acute deep vein thrombosis, from the suspicion of DVT standpoint, she has multiple risk factors. She's been hospitalized recently, had a major surgery. She has a previous history of DVT. She is obese. So if we quickly look at a validated clinical probability score, since she's presenting in the emergency department, and we'll use the Wells score just for the sake of this exercise. She obviously has a history of that. She has active cancer. She has been had major surgery within the previous 12 weeks. She does have pitting edema in the symptomatic leg and a previous history of DVT. So her Wells score is at least 4, which makes her a high pretest clinical suspicion for DVT. In the emergency department, a quantitative D-dimer was elevated at 1200. But as you will see from the simple algorithm for diagnosis and management of DVT, that the D-dimer could have been skipped this step because she has a high pretest probability. And currently the recommendation is to proceed with venous duplex ultrasound of the leg where there's a suspected DVT. And just a few images for you can see. That's a view of her common femoral vein, grayscale. The left-hand panel shows the vein with some echogenicity within. The right-hand panel here shows the lack of or only partial compressibility of the vein. In longitudinal view, you see the thrombus right here. And then in the popliteal view, again, the same transverse image showing lack of compressibility of the popliteal vein and the thrombus in longitudinal view. So our patient has an acute right femoral and popliteal DVT. It is an uncomplicated acute DVT. She does not have like major cerebral dolens. She does not have ischemic limb. There is no involvement of the external iliac vein as far as ultrasound could see. So the suspicion that this thrombus is extending more proximally to the pelvic veins or IVC is low. She has no chest symptoms, so there's no symptomatic PE. She's more than 2 weeks post-mastectomy. She has a normal blood count, normal renal function, normal liver function tests, which essentially means that she has no contraindication to anticoagulation. And I think most of you know that anticoagulation is the mainstay of therapy for an acute lower extremity DVT, like our patient here. And she will be treated with anticoagulation. Now, the choice of anticoagulation will depend. Now, the goals are the same regardless of the choice of anticoagulant. So prevention of thrombus propagation, prevention of early and late DVT recurrence, restoration of venous patency, and certainly prevention of pulmonary embolism. Those are our ultimate goals. And in her case, because she has no contraindication to anticoagulation, that's going to be her initial treatment. And there are different ways to break this down, but given the data on parenteral anticoagulants and direct oral anticoagulants, the initial or acute phase of DVT treatment is generally considered anywhere between 4 or 5 and 21 days. Those would be the choices of anticoagulants for initial treatment: unfractionated heparin, low molecular heparins, fondaparinux, which are the parenteral drugs, and then apixaban and rivaroxaban, the direct oral anticoagulants in this situation. Now, our patient was started on low molecular heparin. She does not have an indication for IVC filter, but I mention it here because this is a question that oftentimes comes up. This is from the latest edition of the updated ACCP guidelines, chaired by the late Clive Kieran from McMaster. And patients with acute DVT who can be anticoagulated, there is a strong recommendation against use of an IVC filter. However, if she had a contraindication, then an IVC filter placement would be recommended. Advanced therapies are not indicated for the majority of patients with lower extremity DVT. Catheter-directed lysis is indicated for phlegmasia serial indolence, but this is a rare presentation. Pharmacomechanical thrombectomy, again, endovascular techniques, they may be considered in patients with iliac DVTs, and IVC thrombosis. It's not routinely recommended for femoral DVTs and really should not be considered initially if it's an uncomplicated presentation. And systemic thrombolysis is really never indicated for acute DVT. So after the initial treatment, then the options of anticoagulation widen. So we add warfarin, we add dabigatran, and edoxaban. So all of these drugs are options for treatment of DVT, whether we're going to treat for 3 to 6 months or whether it's going to be a long-term therapy. Now, a couple of remarks why was warfarin, dabigatran, and edoxaban not included in the initial treatment for the first 5 to 21 days. Well, warfarin, as you all probably know, has to be overlapped with a parenteral anticoagulant for a minimum of 5 days. Here in the US, we call that bridging. It's a transition from the parenteral drug to warfarin, where both drugs are being given every day. And we wait for the INR to go up to the target, which is generally 223 in the majority of patients. Now, when it comes to direct anticoagulants, rivaroxaban and apixaban are the only ones that can be used as monotherapy from the very beginning because they do not require parenteral anticoagulation. Apixaban does require a 7-day of a loading dose that is twice the standard dose. And rivaroxaban requires 3 weeks of a twice daily dose, which is different than the once a day maintenance dose, the standard dose for the remaining of the duration of treatment. Dabigatran and edoxaban, although they are options for VTE treatment, they do require 5 to 10 days of parenteral anticoagulation. That's how the clinical trials were designed. So unlike warfarin, though, this is not bridging. So if you choose to treat with a low molecular heparin for 5 days, on day 6, you stop the parenteral drug and you start either dabigatran or edoxaban. These drugs, the DOACs, all have a very short onset of action. The peak plasma level is within 2 to 3 hours for all of them. So you simply stop the parenteral anticoagulant and begin the direct oral anticoagulants if you are making a transition from parenteral to oral. Now, a few caveats about the direct oral anticoagulants. Patients with renal insufficiency with creatinine clearance less than 30 were excluded from the DOAC trials. We're talking about acute VTE, not necessarily atrial fibrillation. For apixaban, the creatinine clearance was 25 or above in the clinical trial. Extremes of body weight were not included in clinical trials, or they were, but a very few patients, even though recent studies are trying to measure the DOAC levels in these patients. There is a concern if patients have a BMI greater than 40 or a weight greater than especially 120 or 140 kilograms, whether the DOAC's efficacy and safety will be the same. They should be avoided in patients with antiphospholipid syndrome and moderate severe liver cirrhosis. Is more specifically to our patient, there is a specific data available for apixaban, edoxaban, and rivaroxaban in patients with active cancer. The trials of edoxaban and rivaroxaban, comparing them with low molecular heparin, show that they cause an increased risk of bleeding, but they were associated with less recurrence of VTE. Apixaban was also associated with lower recurrence, but did not increase the risk of bleeding. And finally, perhaps one of the important points, which is not very emphasized, is that DOAC should be avoided with concomitant use of other drugs that are potent inhibitors or inducers of P-glycoprotein transporter or cytochrome P3A4 enzymes. And very briefly, focusing on the 10A inhibitors, apixaban and rivaroxaban, 2/3 to 3/4 of these drugs have a liver metabolism, less so renal clearance dependency, especially apixaban, but they are also dependent on renal function, whereas edoxaban, it's about a 50-50 clearance with the liver and kidneys, but they're all substrates of this P glycoprotein transporter in the gut membrane. So a drug that is a potent inducer of this P glycoprotein transporter will lower the level of the DOAC significantly. Every drug that we have pharmacological data showing that it may increase or decrease the DOAC dose by more than 50%, we should avoid the concomitant use. So when it comes to our patient, she was started on low molecular heparin, then switched to apixaban the following day. The type of anticoagulant, though, may have to change depending on whether she's going to need any hormonal therapies for her breast cancer. And just a simple table here to give you an idea, some drugs, anastrozole, for example, actually may potentially increase the level of the rivaroxaban, apixaban. Tamoxifen may decrease, but only mildly so, less than 50%. There should be no effect with edoxaban. It's less dependent on these cytochrome P enzymes for its metabolism. Some drugs will have a much more pronounced potential decrease in the level of the 10A inhibitors, and those should be avoided. So tamoxifen and anastrozole should be used, DOAC should be used with caution unless you're choosing edoxaban. I have several patients with active breast cancer who are on edoxaban exactly because of these hormonal agents that they are taking. And then finally, to conclude, what's the duration of anticoagulation for our patient? We generally break it down to unprovoked, provoked, or provoked related to transient risk factors or a more ongoing risk factor. And the general breakdown here is patients with truly unprovoked DVTs should be considered for long-term anticoagulation if they don't have contraindications to anticoagulation, and the review yearly is really a review for potential contraindications. Certain thrombophilia, perhaps the more severe ones, acquired or inherited, should be considered really for indefinite therapy. But provoked DVT with a transient risk factor would be treated for just 3 months. And the reason for that is because patients with provoked VTE, the rates of recurrence within the first year after discontinuation of anticoagulation is really much lower, 3 to 5 times lower than if it was an unprovoked DVT to begin with. And if you look at cumulative risk of recurrence from some prospective cohorts, the cumulative risk of 5 to 10 years after discontinuation of anticoagulation can be as high as 50 to 60%. So that's why current guidelines recommend long-term anticoagulation for patients with truly unprovoked DVT. Our patient was provoked because of surgery, immobility, but also she has active cancer, which means that she's likely going to be on long-term treatment, but the optimal duration will be dependent upon the underlying disease status, other specific therapies. For example, in this particular case, ongoing tamoxifen therapy is viewed as a reason to continue anticoagulation for as long as the person is on tamoxifen, whereas for anastrozole and letrozole, that recommendation is not really as strong. And the other thing about therapy should be continued until the underlying condition is resolved or in remission. Ideally, we want to make sure that there is no evidence of active cancer before we stop anticoagulation. So I'll stop right here, and I thank you very much for your attention.
Thank you, Dr. Tefera and Dr. Gomez, for very informative talks. We have a couple of questions coming from the audience, but before we go to those, I have a question about the PERT program at main campus. I think the main campus has been a pioneer in many therapies in all fields, but particularly in heart and vascular. There's lots of pioneering efforts, and I think that this is an example of how to do things right in a multidisciplinary approach. And in fact, Dr. Hassam is leading our effort to start a PERT program at Cleveland Clinic Abu Dhabi as well. So the question I had to our colleagues at main campus, if you could comment on the lessons that you've learned establishing this program, and what would be your advice or your recommendations to a program that is attempting to start this sort of a multidisciplinary approach to treatment of pulmonary embolism.
Yeah, I think the lesson learned in particular for me, now I've been involved with 3 different PERT systems at 3 different hospitals, is that from the get-go, getting the buy-in from different departments was the most difficult part. Getting the buy-ins from different surgical departments, as well as the interventional departments, and as well as the primary teams taking care of these patients. But I think as more departments join these PERT calls, they can really see the benefit of these PERT calls. They're really not long, 5 to 10 minutes tops for most of these discussions, and they will see the benefit once they become more accustomed to it. I think the biggest takeaway is to get people to join the calls.
Excellent. I think those are great points. Now, when you were at main campus, was the program already in place, or was this something that has recently been implemented?
For main campus, it's been in place for a long time. I believe Dr. Gomez was here when they actually started it, so I think he can kind of comment on the initial get-go at main campus whenever it was started. But Cleveland Clinic main campus is one of the founding hospitals in terms of the PERT system as well.
Yeah, so thanks for having me. Our original group had vascular medicine staff physicians, cardiology, interventional radiology, pulmonary, internal medicine, and I think one of the vascular surgeons was here at the time, was also part of the group, and cardiothoracic surgery. So it was a truly multi-specialty group, and it's important to have many involved, because these calls happen 24/7, and sometimes it's hard for everyone to join every call. But it also allows the group to become familiar with one another, because oftentimes when we're calling in from home, we are not seeing the patients directly, and it's critical that we know who is seeing the patient and whether we trust the person or the team seeing the patients and making that evaluation, because we're making decisions about potentially life-threatening therapies that we need to be comfortable that information given to us is accurate. The other important thing, I think there was a challenge in the beginning, was that PERT is not taking over the primary care for the patients. So we're not a dedicated consult service that we just take over the care for any submassive or massive PE, but we do need to make sure that the primary service is active and be involved, because we need to collect the data, the imaging information, the laboratory biomarkers, in order to present all complete information. The worst thing that can happen is to make decisions based on incomplete or poor data. And our quality assurance program, which Dr. Tefera has taken over since he joined us, in the very beginning was, I would say, a very amateurish one, but we all took initial pride in doing it as an own initiative. But we did have a couple of patients where incomplete data almost led to a decision that would be less than optimal. But again, having many specialists, different perspectives is very important.
Excellent. Thank you for those insights, and we will definitely be in touch for more advice and recommendations as our program matures and gets through. So the questions from the audience, the first one, and I guess it can be taken by both from a DVT perspective or a pulmonary embolism perspective. So the first question is, what are your clinical criteria for systemic thrombolysis and more aggressive catheter-directed pharmacomechanical thrombectomy?
Yes, I can speak to that in terms of the perspective of PE. Very rarely do we use systemic thrombolytics now in the setting of PE. In terms of clinical criteria for the use of systemic lytics, it would really be a patient that's crashing, or a patient that is hypotensive or has prolonged hypotension or a very high oxygen requirement. But here at main campus, our interventionalists are now so good with these catheter-directed therapies. I would say that in the setting of a patient who's crashing and it has time to activate the cath lab and get the patient for these therapies, we use more so of that. And the patient I presented, that was very early on in the COVID pandemic when we were shying away from catheter-directed therapies just due to exposure. So that patient got systemic lytics. But now we're very comfortable with using catheter-directed therapies, whether that be lytic or pharmacomechanical.
Thank you. The next question from the audience is from one of our critical care physicians who asks that one question that often comes up in the use of thrombolytics in patients who are either traditional anticoagulation or DOAC or coagulopathy, for example, cirrhosis. What is the appropriate dosing of TPA in those cases? One bolus with lower dose or half dose TPA?
So we do try to mitigate the risk of bleeding in these patients that are more high risk. So, you know, if we can not use lytics, that'd be the best answer for those particular patients. But in a patient that does high risk of bleeding and does need systemic lytics, we would use a 50 milligram with a 25 milligram bolus followed by the 25 milligram infusion over 2 hours.
I do want to add, I agree with Dr. Tefera. I just want to add a couple of points. There are really no data on whether using a low dose lytics changes the risk of bleeding. We don't have any larger prospective trials. And when it comes to patients with liver cirrhosis, the more thrombocytopenic they are and the more coagulopathic they are, the greater the risk of bleeding with lytics. That's based on general experience using lytics for different indications, not necessarily acute VTE. So for our critical care colleagues, it's always a challenge because it's not based on data. So you're going to have to decide weighing clinical risks and benefits. And I agree with Dr. Tefera. In those situations, empirically, we would start with a half dose TP alteplase or avoid lytics altogether if we could.
And I think this is really where the decision-making algorithms and kind of discussion that we have in the PERTs are the best in discussing these very difficult cases and seeing what's best for those patients that are not so clear-cut.
Thank you. The next question is to Dr. Gomez. What kinds of GI cancers are contraindication for DOAC therapy? As I have read in an article that colon cancer is not a contraindication in contrast to gastric CA. So what are your differentiating criteria?
Thank you. This is a great question. So when we look at the trials of the DOACs, apixaban, edoxaban, and rivaroxaban, comparing to low molecular heparin, edoxaban and rivaroxaban cause an increased risk of serious or major bleeding, and that was exclusively driven by the risk of upper GI bleeding. There was also some risk of low GI bleeding. There was a trend, but not statistically significant when the study broke down based on bleeding sites. So generally speaking, upper GI tract malignancies are considered a contraindication for a DOAC, for especially edoxaban and rivaroxaban. If the patient presents with a lower GI cancer, so adenocarcinoma of the colon in the case of your question, if the presentation was with a low GI bleeding that was significant, then many individuals would prefer to avoid those DOACs as well. The trial of apixaban did not show an increased risk of bleeding. However, we would still follow the recommendation. If it's an upper GI tract malignancy, we would avoid that as well.
The next question is also for you, Dr. Gomez. Do you consider duplex scan follow-up? So essentially follow-up for DVT while they are on treatment.
Very interesting question. I wonder if somebody trained in Europe. So my answer, I personally do not. I think most of the colleagues that I am in touch with from Canada and Europe also will not use that. However, there are some groups in Europe, particularly I think Italy and Switzerland, that do. And Professor Prandoni in Italy has had studies showing that using residual thrombus as a criterion to extend the duration of anticoagulation. Now, the guidelines by the American College of Chest Physicians, American Society of Hematology have not embraced that concept. So there is some data out there to support it, but generally speaking, it's not something that I use or most follow.
Thank you. There's a question about your indication for catheter-based treatment, size of thrombus, oxygen saturation, hemodynamic instability. I think this was addressed before, but maybe you can do a quick summary on that, Dr. Tefera.
Yeah, it's kind of a data-free range, and that's the reason why we like to use PERS to discuss these cases. But in general, hemodynamically instability patients are the patients that we really consider for catheter-directed therapy. I think one thing that's understated is the trend for the patient. So if the patient is started on anticoagulation and they're doing well and the heart rate's coming down, they're not as hypotensive, these are patients that will not be considered for catheter-directed therapy. But if the patient's being observed in the ED or in the MICU and they're slowly becoming more tachycardic, more hypotensive, their oxygen requirements increasing, these are patients that we would consider for catheter-directed therapy.
Excellent, thank you. And then I'll just take one more question. Can you comment on rivaroxaban duration for COVID patients who already have a high D-dimer, and if D-dimer related age, do we use a separate assessment for patients with COVID? So is there some differentiation in their management?
So the rivaroxaban, we don't have trials in COVID-19 and venous thromboembolism in terms of the duration of anticoagulation. I have personally treated them for 3 months. There are some individuals I know who treat these patients for 6 months. There is no indication, and I would discourage using D-dimer in follow-up because we just don't know what the D-dimer means in the COVID-19 patients who have recovered from the acute illness. Having said that, we know that from the data that have been presented so far, the risk of recurrent VTE after the acute COVID-19 illness is resolved seems to be quite low. I think of the 4 or 5 presentations that have been made at the ISTH meeting back in July of last year and the ASH meeting, I think it was 2.4% at 30 days. And one of the studies I want to say was from the University of Leiden. They looked at D-dimer levels at the 30-day follow-up, and the D-dimer levels were undistinguishable between COVID-19 patients who were critically ill or those who were hospitalized because they needed supplemental oxygen but were not in an ICU. So I discourage you from using D-dimer in the COVID-19 patients. In follow-up, I would just consider 3 or 6 months of therapy and then stop.
I think with that, we are coming to the close of our session. I'd like to thank our speakers for fantastic talks, really impressive work, and all our participants. The questions are still streaming in, but I apologize because I think we have to be cognizant of time because this is a transcontinental talk. Next week, please join us for our session on heart failure management, which will be another very exciting and interesting session. I would encourage you all to join and also have your colleagues join us. Thank you very much, everyone.
Thank you very much, everyone.
Thank you.